Good morning. Welcome to the August 16th, 2018 Public Health Nurse webinar. I'm so glad that you can join us today. My name is Joy Hoskins. I'm the Director of Nursing for the Department for Public Health and the Director for the Division of Women's Health. If your colleagues or peers or other staff are unable to join us today for our live presentations, please know that this session will be available via archived webcast either later today or within this week, maybe Monday, so they can review the material at their convenience. We've got some great agenda items today, and I'm so appreciative of the Department for Public Health staff that is here today and providing technical assistance and a focus on a couple of several well needed topics, and especially with HIV, I wanted to give a big shout out to the reportable disease section. Katie Maya and her team, and Amanda's going to speak with us first to provide a targeted, focused, we'll call it just-in-time training for HIV acute cases and entering that data and surveillance information into NEDS. So it's so critically important, as you all are all aware, to get that data entered in a timely and a complete and a correct fashion. So Amanda's going to give us some helpful hints and some pointers and provide an overview to help you to mitigate, minimize the hepatitis A cases in your jurisdiction and improve the data collection and surveillance as well. So with that, I'll go ahead and turn the camera over to Amanda Hunt, who is a registered nurse, and she works in the reportable disease section within the Division of Epidemiology and Health Planning. So Amanda, thank you so much for being here with us today. You've been a busy lady, haven't you?
Yes.
Okay. Well, let's see here. I'll turn it over to you. There you go.
All right. Good morning, everybody. Going to go through this PowerPoint with you, talk about how to enter NEDS cases for hepatitis A. When I took this over last year, I was promised there would only be like a handful of cases. So it's been kind of crazy. Okay. So our course objectives, we're going to be talking about reporting requirements according to regulation, determining a case using CSTE case definition, case investigation, reporting to DPH, NEDS entry, and briefly go over our supplemental questionnaires. So your reporting requirements come from 902 KAR 2020. Healthcare providers should report the diagnosis of cases of acute hepatitis A within 24 hours to either the local or state health department. Local health departments should report cases of acute hepatitis A to the state health department within 24 hours. Now that's a change since 2015, but that is a requirement now. So let's talk about deciding whether we have a case of hepatitis A. The case definition requires at least one symptom, plus the case must have either jaundice or elevated liver functions. And there are no specific parameters for that. It applies to any value out of range. Plus they must have a positive IgM anti-HAV, which is kind of a mouthful. That case definition is supposed to change or may change in 2019 to include some further parameters and RNA testing. So be on the lookout for that. So your signs and symptoms, you're going to have discrete onset of fatigue, malaise, lethargy, decreased appetite, nausea, vomiting, diarrhea, abdominal pain, joint or muscle pain, jaundice, dark urine, pale stools, pruritus, fever, headache. These are not all of the symptoms that you can have, and there is a PowerPoint presentation made by Dr. Brawley that includes even broader symptoms that you can look at. And the case may have several of these symptoms, or they may have very, very few symptoms. But those signs and symptoms must be listed in NEDS under general comments, or the case will be rejected. I have to have those signs and symptoms to classify the case. Also know that jaundice alone is not sufficient to meet case definition. They have to have other signs and symptoms. A total antibody to HIV is not acceptable for diagnosis. A borderline or indeterminate result is not acceptable and should be repeated. And during this outbreak, providers should consider forwarding reactive specimens to the state lab for confirmation. To begin your investigation, review your reported information. If any information is missing, contact the provider as soon as you can. If a total antibody was performed, request that they provide an IgM or try to obtain one. If those results are borderline, request a repeated lab. Request a specimen to be sent to DLS and attempt to contact your case as soon as possible. So here's a little picture of your investigation process. You're going to start with receiving either a faxed lab report, an ELR, or a morbidity report in NEDS. So you would review your case definition to determine if you have a case or not, contact your provider for any missing info, create an investigation and notification in NEDS, contact your case and interview them, recommend PEP for contacts and follow up, and then update your info in NEDS. I'm going to talk about determining if you have a case. This is a little picture of an example lab report, and if you'll see the highlighted area there, it says hepatitis A, AB total. This is a total antibody and not an IgM. So this is not what you need to determine if you have hepatitis A acute. This is what an IgM looks like. It's going to say on the lab IgM antibody. So this is what we're looking for. If it comes by ELR, you're going to look for that highlighted area there that says IgM, and this is a positive one. This ELR is a total antibody. It doesn't say IgM, it just says HAV, AB, and then all that other stuff. That's just a total antibody. Always follow up on your total antibody lab results. The reason being that the submitter may have selected total antibody when in fact the result was an IgM. You can use this opportunity to educate the provider on appropriate testing for suspected acute hepatitis. And you can request that the ordering provider contact the lab and order IgM testing if specimen is still available. So that's important to know. This is an EPID 200. This form must be completed by the provider. ELRs are not acceptable as a notification for a reportable disease. Some hospitals and providers may argue with you that it is, but it is not. So you should contact the provider if this is not sent to you. So once you have a positive IgM, what are we going to do next? You need to review your medical records. If you don't have them, get them. Does the case have jaundice or elevated liver function tests? And does the case have at least one sign or symptom? If all three criteria are met, you have a case that's reportable. So your contact investigation. Rapid identification and reporting of cases is super important. And this is because you want to take action to prevent transmission of infection to other people and to offer PEP to contacts. The virus is really easily transmissible person to person. Infected individuals can transmit the virus to others for up to 2 weeks before their own symptoms even appear. Cases remain contagious until 7 days after jaundice onset. And close contacts have limited time, just 2 weeks, to receive post-exposure prophylaxis. To determine close contacts, when you interview the patient, you want to know household contacts, sexual contacts, people who may have shared drug equipment, whether injection or non-injection, people who share spaces in congregate settings, and these include substance abuse treatment facilities, correctional facilities, shelters, halfway houses. Shared spaces in those settings include restroom facilities, bunk areas, and shared meal spaces. And then coworkers are not considered close contacts. To protect your close contacts, you're going to use the PEP calculator to determine the case's infectious period. And if you don't have that, we can email that to you. You need to contact your index case, find out who their close contacts are, and recommend PEP for those people. They must receive this PEP within a 2-week window of last exposure to the case during their infectious period. Educate always about proper hand hygiene, soap and running water, and disinfection guidelines. Other things you're going to look at: risk factors, illicit drug use, and that's IV or non-IV, even marijuana, homelessness, exposure to an ill person, MSM, which in this outbreak is not considered a risk factor, travel to an endemic country, chronic liver disease, or close contact with an international adoptee within the first 60 days of their arrival to the U.S. High-risk occupations are going to include food handlers, healthcare workers, daycare workers. They will require work exclusions and further interventions, and you're going to need a little more information about when they worked during their infectious period, their job roles and responsibilities, hand hygiene practices at work, and if they were sick while working, and what were their symptoms. And especially important is, did they have diarrhea while they were at work? Did they have any bare hand food contact? Things of that nature. With these situations, you probably want to get your environmental team involved so that they can visit the facilities and inspect and give information to them as well. This is an algorithm for food handlers determining whether or not people need PEP. I'm not going to read that to you, but just so you have that. Now we're going to talk about reporting. First off, search for your patient. I recommend using the date of birth in case there's weird spelling differences or something like that with names. You'll choose add new if you don't see any records for that person. And if you're adding a new patient, make sure you add all the available demographic: name, date of birth, sex, address, phone number, all that good stuff. So when no records exist, you're going to get a little screen like this that says nothing found. And you're going to click the little tab that says add new. Please always search for the patient before creating a new account. Many of these people have previous investigations for other illnesses, and keeping the records together is super important. You can add a new lab and condition to an existing record, and this is going to save you a lot of time. Please always do this. To add a new lab report, choose Add New by Lab Reports under your Events tab. Search for your reporting facility. This is often the same as the ordering facility. This will not be the local health department. This will be a hospital or a provider. If ordering provider is not searchable, enter their information in comments under Administrative. Your program area, you're going to choose hepatitis. Your county should be automatically selected. And the date received is when you received the lab report. So here's a screenshot of what your search fields look like. This one we searched for hazard, and you can see that it popped up several different selections, and it's got the information, where they're located and things of that nature. So you're going to click select on the correct facility. If you cannot find the facility you are looking for when you use search, cancel your entry. You can email Christy Boland and she can add the facility in NEDS, and then you can proceed with the entry with no trouble. If a panel was received, search for hepatitis panel as your ordered test. After selecting hepatitis panel, enter other information using info from the lab report or the EPID 200. Here's a screen of this. So you're going to click your search, enter your test name as hepatitis, click your submit button, It'll pop up a result there, test name hepatitis panel, and you can click select. Enter each result on your hepatitis panel. You can search for and enter each as separate resulted tests under test results. You have to choose add test result after entering your result. And the tests you may see are your hepatitis A virus antibody, your hepatitis B virus acute core antibody, hepatitis B virus surface antigen, or hepatitis C virus HCV antibody. Choose either submit or submit and create investigation once you've got those in. So there's another screenshot of your hepatitis A lab. Click submit. You'll get the little screen with your different selections there, your hepatitis A virus antibody. That's a total antibody, so you're not looking for that one. The IgG you're not looking for. The third one down, that IgM, that's what you're wanting to see. So you choose select, and then it will give you this screen to put your result in and any other pertinent information. Once you've entered that, you've done that, then make sure you click add test result there in the bottom right-hand corner. So for an ELR report in NEDS, you're going to go to your queue and choose documents requiring review. Then you will select all HAV results that you see there. Just check those. This is an example of your result. You're going to have your reporting facility, date collected, and your description, and just notice that it says IgM there on the end. You can click events to see any investigations that have already been done, and you can see that this person has had 3 separate investigations. The status is closed, and that last one is a hepatitis A acute that's closed. So that investigation is already done. We do see a lot of repeated reporting of these labs. A lot of the cases are visiting more than one hospital or one provider, so that's why you want to look for that to see if it's already been reported. Okay, to enter your investigation in NEDS, if no investigation exists, select Add New. Then select your condition, which is going to be hepatitis. Then click Submit. Then you're going to get this screen, and you're going to select the case's county of residence, which is, a lot of these are drop-down menus. Your state case ID, that's just the patient's NEDS ID, okay? Your investigation start date, make sure you select that. And you can leave this investigation open. Under investigator, you can search, and you are the investigator, so search your name. Then you want to enter all information that's available. So you will need the date of report, your reporting source, which is your provider, your hospital, the dates reported to county, which is you, and then state, which is me, or us. For the physician, you can search, answer if they were hospitalized, select from the drop-down menu. And the areas that I have boxed there, those are the ones that are most important to me. So if you don't have the physician's name, it's not a huge deal. But do try to fill in the boxed areas. Now this is just scrolling down the screen. I couldn't make it one big screenshot because you wouldn't have been able to see it. So this is just scrolling down. The place of birth, I really don't care. Reason for testing, you can pick something there if you want. But these next fields, make sure you enter those. They should be available to you in the case's medical record. We need to know if they're pregnant, need to know their diagnosis date, need to know if they're symptomatic, were they jaundiced, did they pass away. If you choose under is the patient symptomatic, if you choose yes, there's going to be another date box pop up that will say onset date. If you don't know that, that's fine. We're not getting a lot of those because a lot of the cases are, you know, poor historian or lost to follow up. So if you don't have a date for that, that's not a huge deal, but I definitely need a diagnosis date. Then under your laboratory, you'll enter your liver function tests and your parameters, and those should all be on your lab results. And these are just, you just typing in the numbers. Then scrolling down the screen some more, you're going to enter, this is your hepatitis results. So that second one there is your IgM. And these are all drop-down menus. So you just click on it, hit positive. You may have more than one lab, like you may have a panel that will have B and C on it as well. And you can fill those in on this too. Just enter what's available to you. At the bottom, there's a question that says if they're epi-linked. If you know that, you can answer that. All right, we're getting there. Almost. I know it's a lot. All right, scrolling on down, case status. This is required for notification. It doesn't matter what you choose, I can change it. If you want to just put confirmed in there and that'll save me a click, that's fine. But don't stress over that, just put something there or it won't let you create the notification. Under diagnosis, you have to choose, that's a select and choose, hepatitis A acute from the drop down, okay? Then under general comments, I need you to list signs and symptoms, risk factors, things like that here. And there's a variables list that you should have that will tell you the kind of things we're looking for. I absolutely have to have signs and symptoms in order to classify the case. So please make sure you put them here. And then at the bottom, the temperature and diarrhea, you can complete that area if known. If you don't have it, don't stress about it though. Then you're going to click on the acute hepatitis A tab. And these are the medical history questions that you're going to ask or attempt to ask if you can contact the patient. And these are just drop-down boxes, yes, no. They're not a big deal. You know, attempt to get those if you can. And you can complete this section if the case has received the vaccine and you have the information. You'll probably only get somebody that says, oh, I had it in July. Well, if that's the case, then just document it here, or you can even just put it under general comments if that's easier for you. I'm not super picky about this. Make sure you click submit. That submit button is going to save your changes. And you'll note that you have an edit button. You can always edit if you need to. Make sure after you submit your information that you click on create notification. Don't forget, because if you don't do that, I can't see it until I just run across it randomly, and then I'm going to call you and say, why didn't you click submit? This is a sample of one of our supplemental questionnaires. There is a longer version. This is a shorter version that we like to get completed and faxed to us if possible. So if you can contact the patient and get this, that's great. And you can fax it to our secure line, which is listed there. And here are a list of some helpful resources. Remember that on our webpage, we have a lot of information about documents that will be helpful to you. There's a toolkit for environmental. We have a weekly report on there, so make sure you check that out. And then here's our contact information. And thank you all for all your hard work. I know it's hard work. And remember that you can call us at any time. We're fine. You call or email. Please make sure when you do email us about something, you include all of us on that email, because it just makes it a little easier to make sure somebody sees it. We are getting massive amounts of emails, so sometimes we miss one. And if you send it to all of us, then we all have it. And that includes vaccination plans, any questions that you have, whatever it is that you need. Just make sure you email me, Jennifer, and Katie on that.
Hey, Amanda, let them know that the PEP calculator is on the resources for the webinar. They can just.
Oh, the PEP calculator is on the resources for the webinar, and so I believe is the variable list.
If you'll go over all, those are all loaded up for you.
Are they?
Can you find those? If you'll go over those, that would be great.
Let's see.
Can you find them?
That's right.
down just a little bit. Go through all the PowerPoints. Then you have an Excel.
Oh, there's it.
Mm-hmm. So if you want to
Okay.
talk about that, just
All right. I'm not very tech savvy, y'all. Okay, this is the PEP calculator that Dr. Brawley came up with, and you can enter your date of diagnosis here and hit enter, and it will give you the last date to give the vaccine or IG, your first date in your incubation period, and your last date. And then it's got several tabs. This gives you just additional dates. I'm not going to read it all to you. You can read it, but then this again gives you the oldest date in the incubation. There's several tabs, like I said. So you can look at a calendar or you can use this, whichever is easiest for you. And, let's see. And then I have a variables list. All right, here's your variables list of things that we really need in meds, okay? Of course, your general demographic information, patient name, date of birth, gender, address, occupation. If you do come across a food handler, daycare, or healthcare worker, please indicate the name of their employer. You can just put it in the general comments. Hospital, if you have the admission and discharge dates. Reporting provider, if you know, you should have that. Date of diagnosis. Onset of symptoms, remember I said that you may not have that. If you have it, put it in there, but you may not have it. We do need to know if the patient was jaundiced. And we do need to know if they had ALT and AST results. And of course, their IgM results. Make sure you're recommending PEP for the close contacts. And under general comments, you're listing symptoms, whether they're a drug user, whether they have homelessness or contact with the homeless population. And if you know that they have visited particular shelters or camps, you can list those. Also be aware that homelessness includes things like couch surfing, staying in a hotel and renting by the week. Those are, while they're not necessarily homelessness, they are unstable housing. Address of houses where they've been staying, if you have them. Type of activities performed while in a facility, like did they make food for other people. Placement in an institution like a rehab facility or jail, and then names and dates if you have those. Travel in or outside of state. Destination and dates if you can get those. Their sexual history if you can get it. Contact with persons positive for hepatitis A and their names and types of contacts, were they a household contact or what have you. If they have a history of hepatitis A vaccine, try to find out the date. Like I said, if you can only get July 2018, that's fine. Inquire if a specimen was sent to DLS or CDC for hepatitis A virus molecular testing and genotyping. And then some things that you can postpone if you don't have time or can't get a hold of them is their food history, their grocery store, restaurant patronage, attendance of festivals, and exposure to international adoptee. We haven't seen a lot of those, so you can postpone those if you need to.
everybody. Thank you.
Okay, so frequently asked questions. I'd say one is when we have a patient that has symptoms and it kind of falls in this gray area. Excuse me. My children have shared their illness with me. So, you know, you've got a patient that's co-infected with Hep B or Hep C, and they have symptoms of some kind, but we're not sure if they're attributable to the Hep A, and what do we do with that kind of case? And really, I think the best option is to have a discussion with Amanda and find out, you know, really what's going on with that particular individual. If they meet definition at all, so if they have those signs and symptoms and a positive IgM, and elevated liver functions or jaundice, and therefore meet definition, they're going to count it as a case. Unfortunately, with the testing that's included in the case definition, that can be a false positive, but we have to go by surveillance definition. So that is why the confirmatory testing through DLS is so important. We're always welcome questions. Like Amanda said, we're slightly overloaded. So if you email one of the three of us, one of us will get back to you, and we can always have, a group discussion on what you think. We've done that on several occasions and are happy to continue to do that, because a lot of these cases do fall in this weird area. They're not black and white. They can be difficult, and it can be hard to determine what's going on with each person. So give us a call if you have questions. That's one that I think. Food handlers are another particular issue. Do we notify the public when there's a food handler that's a case? Do we recommend post-exposure prophylaxis when there's a food handler that's a case? And that's post-exposure prophylaxis due to an infected food handler is the criteria to meet, that recommendation is pretty rigorous. So we haven't had too many instances in this whole outbreak where we've recommended post-exposure prophylaxis for a food handler, excuse me, to the public. However, your coworkers in that restaurant are always going to get post-exposure prophylaxis. So use that algorithm. Determining whether or not you're going to notify the public is a local health department issue. If you feel like you need to notify them of a very minimal risk because the food handler used good hand hygiene, wasn't really actively symptomatic at work, and the restaurant is super compliant with food safety rules, you can notify the public. We have a template press release available that lots of our local health departments have used. You can modify it to meet your needs at your health department. And then if you do get a case where post-exposure prophylaxis is warranted for the public, we have another template that can be used so that you can make those recommendations. As I said, very few cases have warranted post-exposure prophylaxis for the public. Pretty well documented bad habits going on in those instances. So,
can you talk a little bit about the Hepatitis A website and the data that's posted once a week?
Okay, so since the revamp of the CHFS website, we have our new page up and running. It's a Hepatitis A outbreak page. We have, I believe, I'm sorry, I need to double check. It should be there, but
it is. I double check it every day.
The toolkits and stuff are there.
Oh, yeah, that I don't know. I was looking for the epi reports that you send out.
The reports are posted. So we have a weekly report that is based off the flu surveillance report. We post that every week. We are being more accountable with posting that by close of business on Tuesday, so that everyone, including media, has the opportunity to get that report. We were having a problem with making sure that report was distributed to everyone that needed it. So therefore, we need to be more accountable and consistent in posting it. It's worked for the last few weeks. We're gonna post that on the website by close of business every Tuesday. That way you all have the data for the outbreak. It describes the outbreak in terms of counts, demographics, and risk factor information. We have a couple of epi curves. The newest curve we have on there shows how the outbreak, which was focused in Jefferson County, has now kind of exploded throughout the rest of the state, but is dropping off in Jefferson County, knock on wood, because I don't want to force them back into an upswing. So that's there. We also have discipline and setting specific outreach materials that we've created, and we've distributed those throughout the last several months, but now they were on the website. So you have a toolkit, if you will, for correctional facilities and for congregate settings such as substance abuse treatment facilities. There's also an environmental health toolkit that PHPS here created, which is a phenomenal resource.
It is on the website.
Yes, that is there. That's for your environmental health, excuse me, environmental health specialists that are going to go out and inspect the retail food establishment that a case may be working in. And so, let's see, what else? We have separated the general hepatitis A, you know, what is hepatitis A? How do you get hepatitis A page from the outbreak page? So that's there as well. We have some links to the CDC website, and in Amanda's presentation, she linked you to the CDC's hepatitis A outbreak page. There's a lot of good recommendations and information available on that website as well. And that is specific to these outbreaks that are associated with homelessness and drug use. For the investigator.
Yes, so we do have a question from the audience.
So if you're not listed in NEDS as an investigator, you can contact Christy Boland and we can add you to that list. Don't stress about it. Don't let that hold your investigation up. Go ahead and enter it without that field being completed, and we will get you on that list moving forward. That way you can add it. Just to follow up on Amanda's presentation, there are a lot of fields in NEDS. Very few of them are required, and she pointed out the very important ones. So when you're entering a case in a NEDS, keep in mind what we need to have, and keep in mind what is extra stuff. So the investigator is kind of extra stuff. We want you to be able to track what you're doing, but if you're not in there yet, which I've been an epi, I was a regional epi before this. If you don't know me, I don't think I'm on this list as an investigator, and I've been here since 2010. So it's not a terrible deal, but we will get you in there.
And how would they reach Christy?
I would email Christy.
And how does she spell? What's her email address?
Christy is Christy, K-R-I-S-T-Y .Bolen, B-O-L-E-N @ky.gov. Christy is a former regional epi, and so she may be in the global twice if you have access to that. Make sure you choose the one that is Christy .Bolen.
Thank you.
You're welcome.
Let's talk a little bit about the plans that local health departments would need to submit if they were identified for as a high risk area. And oftentimes the nurse leaders will be assigned that responsibility, Katie.
Mm-hmm.
So could you talk a little bit about what we are looking for in that plan from the department perspective?
Sure. So this outbreak is a little bit different than, you know, H1N1 or flu outbreaks where we are trying to target the public at large. In this outbreak, we are wanting to target at-risk populations for vaccination. So, for example, if you target people that don't have the risk factors for the outbreak and do a mass vaccination clinic, it's not going to do anything to drop our numbers. We have to vaccinate the illicit drug users and our homeless in order to get our numbers to go down. So when you submit your vaccination plan, what we are looking for is that you have identified places in your community where you can reach your illicit drug users and your homeless. So if you have a syringe exchange program, perfect place to give out vaccine. A lot of our cases are in and out of corrections, perfect place to give vaccine. Let's see, if you have homeless shelters, if you have halfway houses that have individuals, you know, coming out of substance abuse treatment and then living there, those would be great places to do on-site clinics, if you will. But we're not looking for community centers, not food pantries. You really want to focus in on corrections, syringe exchange programs, places where you can truly identify that you've got illicit drug users and to a small degree the homeless, because that's not a super large group of at-risk individuals for our outbreak. So the plan is, I'm so sorry, you all. The plan is just a simple Excel document that we have forwarded out, and it from the immunization branch. It's, I think, like 5 or 6 questions, very simple. And you don't have to do anything very detailed. Just tell us where you're going to give your vaccine so we can ensure that the at-risk populations are being targeted.
And if they for some reason need a copy, or they realize that they need to submit a plan, but they don't have that form, can they contact you or Ida Taylor?
They can.
Okay.
Yeah, and please copy Amanda and Jennifer on these emails. Ida is very good about getting back. These ladies, Jennifer and Amanda, are very good at getting back. I am pretty pitiful about email right now. So I promise I'm not doing it intentionally. But if you don't hear from me, follow up with me again or follow up with somebody else and we'll get you a copy. That brings up the tiered funding if you want to talk
Sure,
about that.
absolutely.
We have offered funding to the first round of counties were individual counties that had case counts of more than 5. We gave them some funding for vaccine. Second round of funding, which is currently being distributed, went out to counties with an increased incidence of hepatitis A or an increased count of hepatitis A with a jail or a syringe exchange program where they could administer vaccine. And then our third round of funding is going to go to counties with an increased incidence of drug overdose deaths or hospitalizations and a jail or a syringe exchange program for which to vaccinate our at-risk populations. So that funding can be spent in that county to give out vaccinations. It's, we have a lot of people that we need to vaccinate. It's a small amount of funding, but it is there to help those individual counties that we've identified. 317 vaccine is still available if you are having cases and you need post-exposure prophylaxis. If you have an event that you want to do at corrections or something like that, we can still provide 317 vaccine. But all the rules that go along with 317 vaccine, including, local health department personnel taking it to the facility, administering the vaccine, tracking the vaccine, and then making sure that, the individual vaccines are put into the registry. All the 317 rules that I'm not a great expert on are followed. And funding for 317 is severely restricted because we simply don't have that much. We do hope to have a funding opportunity through the ELC grant coming up, and so we will hopefully get some more counties funded for vaccine. In a similar way, we'll put some allocations into a local health department cost center, and that will be upcoming, but I don't have any great information on how much that'll be.
I may have missed this while I stepped out of the room, Katie, but can you talk about the change in our at-risk population in Kentucky as far as it relates to MSM, the MSM population?
So MSM is a risk factor for hepatitis A, simply because of the transmission of disease. However, in this outbreak, as we're tracking exposure, we're not finding a large number of MSM individuals circulating. We're finding very high percentages of illicit drug users and a smaller percentage of homeless individuals. So we were using MSM exposure as a way of categorizing cases as probable because that may be a risk factor. Thank you very much. For the outbreak, but as we were analyzing the data, we're finding that that's no longer a risk factor that we think is circulating in this outbreak. So what we've done is we've modified our case definition. Anybody with MSM exposure that fits the case definition will still be counted as a suspect case, but they won't be counted as a probable case, simply because we don't have the numbers. If we will be monitoring those cases to make sure we don't have a separate outbreak brewing within this outbreak, and we will make changes as needed. But that's where our numbers on our weekly report were kind of skewed. So as Amanda mentioned, completing these interviews are tough. We're very understanding of that fact. these individuals don't want to talk to us, they don't want services from us, from you all, I guess would be a better way of saying that. And so getting them to call you back is a big issue. You couple that with the fact that you're asking them about their sexual history, that makes it even harder. And so when you have individuals where you have an unknown sexual history, that makes the numbers kind of funny, and that's why the exposure table in the report was kind of off. And so I think taking that out of the case definition kind of fixed that problem.
And kind of along the same lines, what if the local health department, when they review what if the local health department reviews the EBI report one week and they're one color, and then they see their color of their county change due to an increased number of cases? What should the next steps or the action plan be for a local health department who realizes, that their number of hepatitis A cases has increased?
So I think that for every local health department, we need to be proactive. We need to find ways to think outside the box and to identify our at-risk population and how we can get to them. How can our local health departments get out in the community and try to get these individuals vaccinated? I wouldn't concentrate too much on, when you change from red to blue or red to green or whatever. Basically, that is just us trying to come up with a distribution for that map. What we need to do as a state is to vaccinate those people at risk. If you have one case, if you have 500 cases, we need to vaccinate. And so we shouldn't be waiting until we change colors or until we get to 5 cases or 10 cases or whatever. Start now. If you have 0 cases, maybe you can prevent it from coming to your county. If you have 5 cases, maybe we can prevent it to getting to 10. Just be proactive, think outside the box. There are a number of different things that I can think of that may be appropriate for one county that are simply irrelevant to another county. So you all are the subject matter experts on what providers you have and how to get to those at-risk populations. It's going to be very hard for us to say more than a couple of ideas on how to get to your illicit drug users.
Yeah. Certainly, all things are local as far as the strategies and interventions, but from a little bit broader context, could you talk a little bit about Kentucky's partnerships and collaborations with the contiguous states? And because that will certainly impact some of our counties that are, right next to to Cincinnati, for example.
So we have so graciously shared our outbreak with it might be all of our adjacent states at this point. Yeah, so pretty much all of them. And that's because our population is mobile. They don't stay in one place, they go back and forth. And so we're seeing cases in West Virginia, Ohio, Tennessee is starting to see some cases. I think there might be a little low, I can't remember. But we are having bi-weekly calls with these states to keep up with what's going on there. We're sharing materials as we can with them, and they're sharing materials with us. I think in general, our responses are the same, but Ohio is going to vary from Kentucky, who's going to vary from Tennessee. So if you have any questions about what's going on across the state borders, please let us know. If you need to get in contact with somebody, let us know. Most of our border counties have pretty good relationships with those counties across the state line. So use those relationships.
Jennifer, I want to give you the opportunity. Anything from an EBI perspective? Let Katie I'll let Katie have a break here just for a minute. There's probably some regional EBIs participating in today's webinar. Anything from a data collection perspective that perhaps Amanda didn't cover that you would like to emphasize?
I think Amanda covered a lot of it because most of it was in the PowerPoint.
Okay.
One thing that I would note is if you do identify someone that says they have a contact, maybe try and learn what the contact's name is or what the extent of their relationship is. That helps us kind of figure out if this person that has no risk factors is exposed to someone that does have risk factors or something along those lines.
What about a local health department who may not have a regional epi? And this may be a question for you, Katie. How would a local health department, gather their resources, perhaps tap into DPH resources to be able to get the surveillance done and the data collected as they need?
So in those areas without a regional epi, the local health department nurse that's doing your communicable disease follow-up, gather as much evidence as you can. Use the resources that Amanda has provided today, the variable list. And if you're having trouble with NEDS entry, call the infectious disease consultant that covers that disease. So for hepatitis A, that's Amanda. That list is out there. All of the consultants here at DPH are perfectly happy to walk staff through NEDS entry. I think that's the hardest part. So our local health departments are great at investigating cases. It's usually just the NEDS entry that's a little bit foreign. You all know what you're doing. You know what questions to ask. It's just a matter of documenting those. And so call your infectious disease consultant and let them help you get through NEDS entry.
That's good. And then what about opportunities for partnerships and training and technical assistance with perhaps partners within the local health department's community, such as hospitals, I'll just say, who may or may not be subject matter experts as much as the local health department? How much, what do you all envision or see as far as training and teaching hospitals or other healthcare providers in the local health department community as far as data collection for hepatitis A?
So I think it can be broader than just hepatitis A. So having a good relationship with the infection preventionists at your local health at your local hospitals is very important. Providing them with the regulation. That 9022:020 that's really the framework for what they need to do. So I know it's boring reading. Nobody wants to sit there and read that whole rig, but it has definitions. It has a description of everything that your local hospital needs to do to report cases of any reportable disease. So share that with them. Have lunch with them. Go over and talk to them. Form a personal relationship with them. That way, when you call, it's not a burden to get information.
It's not a cold call.
Right. And they know who they're talking to. They're not afraid to give you information. A lot of times when you call a hospital, they will want to send you to medical records to get information. If you use your infection preventionist, you don't have to go through medical records. Some hospitals have policies where they won't release medical records until an individual is discharged. That's not an issue if you have a relationship with your IPs. So definitely, if you don't have a regional epi, work with your IPs in your local hospitals. Sometimes if you have a big system, they might be in a different county, work with the regional epi in that other county, talk to them, work with them. And my experience with them on the local level is they'll do anything for you. You just have to work with them. You just have to talk to them. They have to know who you are. And then if we are coming up, regional EPIs right now are local health department employees. If you are having trouble keeping up, if there is a huge issue, with surveillance that we need to discuss on a higher level, then we can discuss maybe sharing assets across county lines. That's an opportunity, but it will have to be a bigger discussion. When you've run out of all your resources at the local level, then we can discuss resources from a state level. We greatly appreciate all the work that you all are doing. We know it is exhausting on all levels to continue with this outbreak. It's unprecedented. It's not something that we've had here in Kentucky, something of this magnitude before. We can't thank you enough for all the work that you're doing, and we're here to assist as much as we can. So let us know if you have questions. If things come up later, please just reach out. We'll be happy to schedule whatever we can. And thank you.
Yeah. Thank you, Katie and Jennifer and Amanda. Before I let you go, would you mind to send me the list of contacts in the reportable disease section? Because we have a lot of new nurses out in the local health departments, if we could just send that list out again for those who may not have that list readily accessible. And then if you wouldn't mind to send me the reportable disease regulation,
Sure.
I'll send that out as well so everybody can have that right at their fingertips.
Sure.
Okay?
So just really quickly, the reg changed. I think the most recent version is November of 2016. So we had 2 changes in 2016. So make sure you're looking at the November 2016 revision. And then for the ID consultant list, we've had a lot of turnover upstairs. So I will send what is available now,
Yes.
and then be on the lookout for an updated list, because we do have changes in the reportable disease section as well as the immunization section.
Yes.
So be patient with us.
Yeah.
If you call any of us, we will get you to the right person. So
Yeah.
if you can just get to somebody up here, we'll forward you on. Okay.
Yeah. Thank you, Katie and Jennifer, Amanda, again for your presentation today and for all of your knowledge and expertise and technical assistance that you provide to us here at the department and especially to the local health department. So we appreciate you all as well.
Thank you.
All right. Thank you. And I'm certainly no Barbara Bailey, so. But anyway, I knew you knew all those answers, so that's why I felt comfortable asking those questions. I appreciate you being so receptive to me asking all those questions. All right, have a good day. Next, it's my pleasure to introduce Gail Yoakum. She is with our Department for Public Health HIV program, and she's going to talk with us today about HIV testing. And then the second part of the presentation will be provided by Bob Ford, who is also with the HIV program. And I've got your presentation all loaded up here, ready to go. And Bob will be talking to us about the HIV adult documentation form. So I'll pull up Gail's, she's looking for the port here. We've got you all pulled up here, ready to go, okay? There you go. Thank you, Gail. There you go. And then the camera's right here. And then you just advance your slides right there, okay? All right.
All right, so good morning, everyone, and thank you for being here today. It's a little wet and drippy here in Frankfurt, but that's okay, I suppose. It could be snow. So appreciate the opportunity to talk with you today about HIV testing. And unfortunately, it is still alive and well, and we're seeing increases in youth and young adults and in the population of 20 to about 39 years old. So there still is very much a need to promote HIV awareness and testing, and to make sure people know that they need to understand what their status is and their risk factors. So the federal grant that the HIV prevention and surveillance programs are working under is PS 18-1802. And this is the first year of an integrated grant between the two programs. And CDC is very strong on advocating using data to drive your prevention efforts. So your test score or your test come in as a vital component of that when we're looking at where we're finding positive cases and the need to direct our testing efforts in those areas. The MMWR provides guidance for testing in all healthcare settings, and HIV screening is recommended for all patients in healthcare settings after the patient is notified that the test is going to be performed. So Kentucky has an opt-out law, And your normal testing form for other STDs certainly includes HIV, but you are required to ask the individual if they are okay with having an HIV test. And just a little aside here, we were doing an HIV training, the fundamentals of HIV prevention counseling, and doing a role play. And there was the tester approaching the client or patient and said, "Do you want an HIV test?" And the whole time her head is shaking no. So we have to be really conscious about any subliminal messages that we may be sharing with people. Of course, persons at high risk for HIV should be screened annually, and those high risk include injection drug use, unprotected sex, and sex with multiple partners. And we just talked about the written consent. A separate form is not required for that. And they have really streamlined the counseling components. So those of you who have taken the fundamentals class before, it's been pared down. So if you have an individual who has previously been tested and they're coming back for an annual test or even another 3 or 6 months test, it's not necessary to go through that entire dialogue with them. Looking at the risk factors is the most critical in helping people to understand the transmission methods and how they can prevent transmission. Screening should be included in the routine panel for all prenatal tests for pregnant women. It's also recommended after the patient is notified that testing will be performed unless the patient declines, which is the opt-out, which we've talked about. Requirements to provide HIV testing are listed in KRS 214.625, and it says no public health department and no other person in this state shall conduct or hold themselves out to the public as conducting a testing program for acquired immunodeficiency syndrome, acquired immunodeficiency syndrome related complex, or human immunodeficiency virus status without first registering with the cabinet, complying with all other applicable provisions of state law and meeting the following requirements. The program shall be directed by a person who has completed an educational course approved by the cabinet in the counseling of persons with HIV/AIDS. This program is the fundamentals of HIV prevention counseling. And I know we have a lot of new staff out there. I've had some calls from some nurses at local health departments who didn't know anything about what we call the FHPC training. So we are in the process of helping people to gain access to those modules through Kentucky Train. And then as we get enough individuals who have completed it, we'll be scheduling classes for the one-day skill building session. More about KRS 214, and I'm not going to take your time to read all of this. So the fundamentals of HIV prevention counseling is the approved and mandatory class for anyone who provides HIV testing. And those are located on kentuckytrain.org. If you don't already have an account, it's very easy to establish one. You create a username and a password. And then you see the course numbers listed here that are the prerequisites to the one-day skill building class. And then the workshops are posted on Train, and you go on and register for that. We try to host these one-day trainings in areas where we have the most staff to eliminate large travel distances. And Lincoln Trail District has 10 nurses who all need the one-day course, and we're going to their health department there in Hardin County to provide the training.
So that option, if another local health department had a large number of nurses, or 2 or 3 local health departments got together, you would be able to provide a PRN training.
Absolutely,
Okay.
absolutely. But you have to take your prerequisites first. And they're 3 days worth of training condensed into modules. So it's not a quick read, but I think it's very interesting and very informative, and will certainly help you to get a feel for how to approach an individual regarding taking an HIV test and how to provide those results. So some of you may be familiar with the HIV test form. We have that on the screen now. And the federal government requires that all HIV test forms that are, let me back up, that all HIV tests that are paid for with the PS 18-1802 grant funds be documented and recorded in Evaluation Web, which is a federal database. So the form has basic information on it, starting with the form ID. That is your Kentucky sticker number. And there's a slide on over with the information of how to get those. There's no reason to ever put a name on this form. HIV counseling can be anonymous or confidential, and we really do promote confidential testing. So if there's a need to get in touch with that individual, you'll have a place to start. But they are not required to give their name, and we certainly don't need their name here in Frankfurt. So the Kentucky sticker number is sufficient for that. And then all of the fields on the form have to be completed. And if we get an incomplete form, if there's just an item or two, we'll give you a call back and ask for that information. We had about 20 forms that came from one health department that were incomplete, and we just batched those and mailed them back so people could look up that information and return it to us. You put the type of test that was provided, whether you're doing a rapid or a venipuncture, and then the results of that test. And let me see if I can, it won't move down. And then if that test is reactive, if you do a rapid test and the test is reactive, that would be followed up with a second test to confirm. So there is a space for that second test as to what type of test was provided, whether or not the individual received their results. And then there's a page 2 of this form for all positive tests that has to be completed. There's number 4, positive test results. Did the client attend an HIV medical appointment after this positive test? And you may not know that. You might refer them on to a medical provider. But if you do know if they went, it's great if you can put that on there. A new field this year is regarding PrEP. And that is really being promoted by CDC as a very effective prevention tool. It is a medication that has to be taken every day, and I think of it as birth control pills. It doesn't work if you don't take it, but if you take it, it's very effective. And for those patients that you see that have really substantial risk, you may want to discuss PrEP with them. And we're trying to compile a list of providers for PrEP, and I would really encourage you to talk with your staff there to see if the physician or the nurse,
The APRN?
yes, can prescribe that. And there are some labs that have to be provided along with that at intervals to make sure that there's not any liver or kidney damage. Several people have asked about a code for HIV tests conducted in their syringe exchange programs. And at this point, what I would ask you to do is on the top of your test form that you send into us, just mark SEP. We're trying to figure out a way to create a different code for that for health departments who enter their own test forms. When you go into Evaluation Web in your drop-down box for site, SEP is an option. But for those health departments who send them here to Frankfurt to be entered, just put SEP on top, and that way we can get it entered accordingly for you. Again, complete all fields on the test form. Kentucky stickers can be obtained from Kay Loftus, and her email address is there. And I would ask that you submit those forms monthly. This is how the health department gets credit for the number of HIV tests that they've completed. And those forms can be mailed in to Kay. She brings them to the prevention office, and we have a data entry operator who gets all those forms in. And you can get reports about the number of tests that have been conducted in your county, what the risk factors were. If you're interested in that, just give me a call and I'll be happy to get that for you. With a reactive HIV test, we have used the rapid algorithm for over a year now, and it's a very good method to get individuals who have 2 reactive tests linked into care. At this point, CDC is only recommending the rapid algorithm in non-clinical settings, but we are defining the syringe exchange programs as non-clinical. So for those who have an SEP, you can use the INSTI test, which is the greater sensitivity and specificity, and it's only 60 seconds. So if anybody has, I've got to hurry up, I need to leave, 60 seconds. That's all it's going to take you to get your test, and then you'll know, and hopefully that will be a comfort to them. So if that INSTI is reactive, you would follow up with the sure check, which is a little bit longer. But if both tests are reactive, it's pretty sure that that individual is HIV positive. And you can make an immediate referral into a Ryan White program or onto a medical provider. And then when they go for that appointment, they will draw blood to determine their viral load, and also as another confirmation of the test. Training for the INSTI will also be provided during that one-day skill building session. So I've had a lot of people that wanted to order the INSTI, but they hadn't been trained. You have to be trained before you can do the test. But if you haven't had the INSTI training and you have already completed the fundamentals of HIV prevention counseling, and you're really wanting to implement that test, we can try to link you with maybe one of your neighboring counties who may have staff who have already been trained, or we can try to arrange for a DIS who's been trained, or one of the prevention staff to come and provide that for you, because it really is a very good test. Those tests are ordered on a quarterly basis, and we have a master list of contacts for all the local health departments. Again, there's a lot of changes, and if you all think about it and can let us know the new contact person, that would be fabulous, because what happens is the email goes to that contact person, And then if the company doesn't hear back, they notify me and say, we haven't gotten an order from whatever county. And then I follow up on that. Now, if something happens that you don't need to order tests at that quarterly mark, but you run out or you run low before the next ordering cycle, there is absolutely no problem with you ordering in the interim. And it's a standard form for the ChemBio as well as the biolytical. And I would hope by now everybody would have had that form. If you need it, you can email me and I'll be happy to send it to you. These order forms must come back to me. The companies will not accept them directly from the health department. They have to come through the prevention office for review and approval, and then I submit them to the company. And I try to submit them on the day of receipt from the health department staff.
Gail, one question, if I may interject. Do you happen to know, I'm assuming that the SureCheck and the NSTI are waived
Yes.
CLIA tests. Would you mind just to, share that with the group, and that you all would need the local health departments for your laboratory services and your CLIA certification? You would need to, compile all the information about the training, staff training, and the return demonstration and competencies for those tests, as Gail mentioned, and with the training. And then also you'd want to be sure to have your standard operating procedure on file for those tests as well,
Right.
for your waived CLIA certificate.
Right.
Thank you, Gail.
And if anybody needs those procedures for NSTI or the SureCheck, let me know and I'll be happy to send those out to you.
They're already written. You don't have to write them.
Yeah. All you have to do is put them in the file. So that's all that I have for my presentation. And, I just really encourage you to promote HIV testing in your health departments, and especially for women who may be coming in who are pregnant, to have that test during their first trimester. And it's just so important. It's a preventable disease, and you can still order condoms through the STD program. They will send those to you directly. And if you need any kind of brochures on HIV, we have stacks that we would be happy to put together in a box and send those to you. So the prevention staff are here for your support and your assistance. And all you have to do is call us. If you have questions, feel free to call. We have 3 program coordinators. One who focuses on the MSM population, one who focuses on transgender, and one who is focusing on harm reduction. And when I say focus, that's their primary work, but anything HIV related they can help you with. I'll also let you know that we have many grants that are associated with all of the HIV awareness days. So if your health department wanted to do a special event, say December 1, World AIDS Day, we should all do something for that. You can apply to our office for the mini grant, and there's a form that we have that we can send to you. And you talk about what your event will be, the audience that you're hoping to reach, whether or not you'll be providing HIV testing, which we encourage, and develop a budget for that. And we can pay for things such as a meeting space, if that's needed, promotional materials, light refreshments for the group, if you have some type of reception, if you have a speaker that comes into the event, and we can pay them an honorarium. So it's a variety of things that we can do for those mini grants. And those,
I was just going to ask, how much money would those be available for those grants, or does that vary?
It varies by the event that you're doing, and the number of people that you hope to serve during that event. But it is some extra funds that we can get out into the communities to promote HIV awareness and education. So please take advantage of these. And they don't have to be huge staged events. They can be putting up posters in your community, or running an ad in the newspaper, or having a speaker to come in and talk with a group of community partners. So,
And then I have a couple of questions for the training, the 4 train module numbers. Is that information available in the administrative reference, or where could they identify that information if they, didn't have the
it's on the
PowerPoint?
state website.
Okay, so they would go to the state website.
Go to the state
prevention
website
page.
and look under the HIV branch, and you would look under HIV counseling and testing education. And it will have all your modules there. Greg Lee, who deserted us through retirement, put all that information together, instructions on how to set up an account in Train. So it is all there on our webpage. And if you have any challenges with that, feel free to call and we can try to walk you through that. You do need to take an assessment at the end, and in addition, get your certificate. You'll need that for your personnel record. And once all that's completed, you can look for a class that is the one-day skill building session. But as Joy mentioned earlier, if there's a health department or a district that has several people that are needing to take the class, we can try to make arrangements to come to your area. We're glad to do that.
And your website link is working.
It is, well, it
Because
was.
there's so many links that have been broken during the website transition.
I tried it yesterday
Oh,
afternoon.
good.
And
Okay.
it was working.
Good, okay. And then one more question. I wanted to learn a little bit more. Maybe there's some folks out in the field who maybe new, may not be as familiar with the PrEP.
Mhm.
And so are there regional providers who provide, that the PrEP, or how would a local health department go around, identifying a local or a close by partner for PrEP?
Finding a provider can be challenging. If you are anywhere near Jefferson County, there is a PrEP clinic that is operated through the University of Louisville with Dr. Krieger. Everybody that goes there can get all their lab work done there. They can get the HIV testing there as well as their medication, and they can work with the patient on accessing resources for payment. Some insurance will cover PrEP. Gilead, who makes the medication, offers, I think they've now moved it to 6 months of financial assistance for paying for the medication. So that's a big help to people. Probably the best way is to call your providers and engage them in some discussion as to whether or not they are aware of PrEP. A lot of medical providers really don't have any or sufficient knowledge on PrEP to be able to provide. And if you find that to be the situation and they're wanting additional information, please reach out to our office at 502-564-6539, and we can send resources to that medical provider. The University of Kentucky has not a PrEP clinic, but they do have providers there at the hospital and Kentucky Clinic that provide. And it's really just searching in your area to see who is willing and able to provide that medication.
Great information.
Thank you all, and thank you for all that you do and for getting those forms completed thoroughly and sending them in to us, because we certainly want you to get credit for the work that you're doing. And, I hate to see a year come around and a health department hasn't had any HIV tests. That makes me wonder if there's something more we need to do on our end to support your work. So if there is, feel free to give us a call. Thank you.
Thank you again, Gail. Screen up here. Okay. I'd like to introduce Bob Ford, who comes to Frankfort by way of Northern Kentucky area with many years of experience in HIV education, training, technical assistance. So we're so fortunate to have Bob here with us in Frankfort now, and he's going to talk to us today about completing the HIV adult documentation tool. And so this will be a great opportunity to ask Bob questions about completing the form, so forth and so on. And Bob, if you have any other information you'd like to share, as a part of your presentation, now's your opportunity. You've got the camera right there in front of you, so you can go right ahead.
Cool. Good morning. Thank you for joining us. It's wet here in Frankfort, and I heard it was wet up in Northern Kentucky, so it's probably wet where you are too. We want to go over the adult HIV case, the HIV adult case report form. We're going to go over some new sections that have been added to the recent update, where and how to enter some of the diagnostic tests, some tips for you in completing the form, and who to talk to for help if you need it. The adult case report form can be found at the address on your screen. I checked this the other day and it did work. They are in the information is on the court clinical guide as well. Joy, that's in, I guess you can.
It's in the form section.
It's in the form section.
Yes, sir.
And there's also an HIV section. There's information there as well.
The form section under the HIV form heading.
Okay, great. Thank you. Our main line to call and report a case, if you wish to do so or want to call in the case, is 866-510-0008. You'll talk to either Julie Nakima or Julie Kozlerich. They'll take the case, and I can take a case as well. And this is my direct line, my extension, 502-564-6539, and my extension is 4290. We're going to review the new sections, and then I'll give you some more specifics about each section. Some of the new sections are in the clinical part, and it's about acute HIV infection, and that's in the acute HIV infection and opportunistic illnesses, and that's at the bottom of page 2. If you happen to have the adult case report form handy and want to pull that out, it might be easier to follow along with the actual form in front of you. Drug resistance testing, the genotypic testing, that's 2/3 down on page 3, that's a new section. And then the question, evidence of receipt of HIV medical care other than laboratory results, is inside the treatment services referral box, and that's on the top of page 4. So here's a screenshot of the acute HIV infection and opportunistic illnesses. So we're asking, suspect acute HIV infection? If yes, complete the 2 items below, enter the documented negative HIV test data in the laboratory data section, and enter patient or provider reported previous negative HIV test in the testing history. So we're looking to see if there's been a negative HIV test at any point in the patient's history of the service they've had with you, or at least within the last 120 days. Clinical symptoms consistent with acute retroviral syndrome, fever, malaise, fatigue, myalgia, pharyngitis, rash, lymphadenopathy. I said that wrong, I apologize. And then when did those symptoms start? Have they had flu-like symptoms? And we need a box marked, yes, no, or unknown. Other evidence suggestive of acute infection, what have they told you, or what information have they given you? Well, why are we asking you to track acute infection? Very simply, it's because someone with acute infection can more easily transmit HIV during the acute infection period to their sexual or their needle sharing partners. So something to think about when somebody comes in for their HIV test. Within the last 120 days, is this a follow-up test because you gave them a negative test a few months ago and you told them to come back in 3 months? Was that test an indeterminate test? Or did you do a test and you got conflicting test results? Or are they coming in and telling you that they got a home test and they got a positive on a home test? Is the patient reporting sexual or needle activity with clear risk? They come in, they want an HIV test because they've told you that the partner or partners that they have told them that they're HIV positive. Is the patient reporting sexual assault or occupational exposure, and has that been within the last 120 days? Is the patient presenting with those flu-like symptoms we just discussed? And did those symptoms start within a couple of weeks of a sexual or needle sharing experience where they may have become infected? The new other section is the drug resistance test. That's genotypic testing. That's looking for the drug resistant strain of HIV, strains of HIV that can be transmitted during sexual and needle sharing activity for somebody who is not on successful treatment. Again, that's 2/3 of the way down on page 3. It's a new field. I just wanted to bring your attention to that. Our local health departments do not at this time provide genotypic testing. So this is probably something you're not going to ever be filling out. This may only be a case where the patient brings in those lab reports from another doctor. Again, if they've got genotypic testing going on, we would be interested as to why they would be coming to you for a confirmatory test. But the patient may be saying, I've been told I'm positive, here's my information, but I want to be confirmed. So just collect their information and go ahead and do their test. Evidence of receipt of HIV medical care other than laboratory results. Again, this is a new section. It's inside the treatment services referral box, and that's at the top of page 4. Has the patient mentioned taking any medications associated with HIV, or has the patient mentioned seeing an HIV specialist? That would be some of the evidence that we're talking about. Medications associated with HIV could also be misconstrued if you don't ask exactly the right questions for PrEP that you've just discussed. PrEP is for somebody who is HIV negative, not somebody who is HIV positive. Now, you could also have somebody who's on PrEP who didn't take it correctly, who is now being diagnosed as HIV positive. So they're in care not for HIV, but they're in care for prophylaxis. They're not in care for HIV. Now they're being diagnosed, they're starting care for HIV. We can help answer those questions and tease out the accuracy of the information that you're given. Check the appropriate boxes below and make any notes that you need us to know in the comments section. I'm going to review where and how to enter the diagnostic test, and then we'll step that out a little bit. The diagnostic tests are reported on page 3 in laboratory data. We're asking you to provide as much information as you are able. The state lab runs Bio-Rad antigen antibody testing, and if that is repeatedly positive or repeatedly reactive, they will conduct the Bio-Rad Genius confirmatory test. On the adult case report form, that enter the point of care finger stick in test 1. So most of our county health centers are now doing finger sticks as the first diagnostic test for HIV. That needs to be entered in test 1 on page 3. The Bio-Rad HIV 1-2 antigen antibody state run test is now test 2. If you get a reaction to both of those, the Bio-Rad Genius state run confirmatory test will be entered under HIV immunoassays differentiating. On occasion, the antigen antibody is positive while the Genius is negative. The state lab will recognize that difference because both of those are state run tests. The state lab will recognize that difference and send a sample to APHL, another lab, for qualitative RNA. Qualitative RNA confirms that there is presence of HIV infection. It's different than quantitative RNA. Quantitative RNA for HIV testing tells us how much HIV is present in the sample submitted. In HIV immunoassays non-differentiating, test 1. This is the information that we'd like you to enter. So this is the HIV 1-2 HIV antibody test. That's the SureCheck brand. The result as appropriate, HIV positive or reactive, non-reactive, or invalid. The collection date, that's the date you stuck their finger. And the point of care rapid test, that's what this is. It's a point of care rapid test, and there's a little box on your form. We'll ask you to check that. Test 2, if that test 1 is positive or reactive, Test 2 is one from the state lab. That's the HIV-1/2 antigen antibody test. The brand name is Biorad. State lab is the lab name. The result is appropriate, and the collection date, the date that you drew the blood. Probably the same day you stuck the finger. The immunoassays differentiating test, that is the reflexive test that's done if the HIV-1/2 antigen antibody done by the state lab is reactive. It's called a confirmatory or supplemental test. Please mark that box. The test brand name is Biorad as well. The lab name, of course, is state lab. And the overall interpretation is what you'll receive back from the state lab, and mark that as appropriate. And there are a couple of different answers for that. So here is a blank form. And do we have a, okay, good. So test 1 would be HIV-1/2 IA. It's the point of care test. We talked about that. The collection date is the date you stuck your finger. And the result, of course, would be positive on this form. HIV test 2, that's the state lab. That's the HIV-1/2 antigen antibody. Lab name is state lab. Test brand name is Biorad. Collection date is the date you drew the blood. It is not a point of care test. You're drawing blood. You get a result back, it's probably going to be positive on that. HIV-1/2 type differentiating immunoassay, that's the confirmatory test. And you see either screening initial test or confirmatory supplemental test. For us, it's the confirmatory supplemental test, so I'll ask you to mark this box. The brand name is Biorad, the lab name is state lab. And then overall interpretation. More than likely, if all of these are positive up here, this is going to be HIV-1 positive that you mark. You can see all these different results because it's looking for a whole bunch of different things. Do the collection date. At some point in the future, you're going to be receiving the analyte results. You don't receive that now. I talked to Matt Johnson at the lab. You don't receive that now, so we're not asking you to report that. If there's a discrepancy, there's my cursor, if there's a discrepancy between test 2, the HIV-1/2 antigen antibody, and the differentiating immunoassay, you'll also receive the qualitative test from the state lab. And you can mark that as HIV-1 RNA DNA NAAT qualitative. The brand name, manufacturer I did not get, I apologize. The lab name is APHL. The collection date is the date that you sent in the sample to the lab, and the result will be positive, negative, or indeterminate based on what the state tells you. So here is a sample form filled out. So test 1, just what we talked about, HIV-2/1 IA, it's sure check. You're doing it as point of care, the collection date, and the reaction is positive. Test 2, you're getting this information back from the state lab. So the state lab name, Biorad, collection date is the date that you drew the blood, and that's going to be positive. You're getting results back. It might be negative. So if you have a positive HIV-1 test or a positive HIV antibody test on SureCheck and then a negative Biorad test, the state lab is not going to do any more testing. You'll need to give direction to your patient as to what to do in that circumstance. If both the HIV-1 antibody test, SureCheck is positive, and the Biorad HIV-1/2 antigen antibody test is positive, they're going to do the differentiating test. You can see how that's filled out. So what mistakes did I make on this? I did not put collection date on test 2, and I did not put collection date on the HIV immunoassay differentiating. We really need that information. And I also used cursive writing, and we'd prefer that you print. So can we open to questions to the floor? Oh, there we go. Okay. So here's some tips as you're filling out the form. Don't forget to complete the HIV test form part 1 that Gail talked about for all of the HIV tests conducted at your site, and HIV test form part 2 for all of the reactive HIV test results that you receive. This part, HIV test form part 1 and HIV test form part 2 are different and separate forms from the adult case report form, and all 3 need to be filled out on somebody who's HIV infected. Of course, you already know that HIV is a reportable condition. And while the HIV test form 1, part 1, tracks the number of tests performed, it does not satisfy the requirements for reporting. So we need you to fill out all 3 forms for somebody who is reactive or positive. Please include the collection dates on all samples of all tests run. And please include the manufacturer's name and the rapid test used. Our disease investigation services will need this information when they're doing their investigations. You may have already heard this, but I want to confirm that all newly confirmed HIV diagnoses will be forwarded to our disease intervention specialists for follow-up on all of those HIV cases, and they will follow up as they are able. If you want to mail in your completed adult case report form, please place both forms inside 2 sealed envelopes, mark both of them as confidential. When you're ordering your HIV labs from the state lab, and Matt told me this, be sure to mark the box or note that this order is because of a positive rapid test. And then mark unknown or enter a dash in any field on the adult case report form if you cannot find out the answer or do not know the answer. If you have a social security number, a full social security number, or the last 4 digits, we'd appreciate having that information. And there is no field on the adult case report form for social security number. That highlighted box that you see just says asterisk number. Just write in SSN and then the social security number for that patient. We need to know how the person may have become infected with HIV, and they're very specifically defined. This can be done through a conversational strategy rather than reading out these questions to your patient. How did the person become infected? If it's a male and the male is also diagnosed with anal syphilis, you can make the presumption that he's probably had sex with another man. But we need to talk about, how do you think you got infected with HIV? Was it your sexual partners? Was it your needle sharing partners? Was it a combination of both? Mark yes, no, or unknown based on the patient's responses. And please respond to each one of the questions if you're able. In patient demographics, we get a lot of questions about the country of birth. In patient demographics, we do want their county of birth or the county of their residence at the time of the test. But we also need to know, where were they born? Were they born here in the United States, or were they born outside of the United States? In order to report, we have 2 sites. If you're in those counties listed, Jefferson, Henry, Oldham, Bullitt, Spencer, Shelby, and Trimble counties, you can call Nichelle Anderson at the number on your screen, 502-574-6574. She can take the report over the phone with you, or you can mail it into her at the address, Louisville Metro Health Department, 400 East Gray Street, Louisville, Kentucky, 40202. Attention, Nichelle Anderson. Again, the adult case report form should be folded, put into 2 envelopes, both marked confidential. Everybody else gets sent to us here at the state. Julie Nakima has been around for about 10 years. She's excellent at taking the information from you and will ask all the right questions. Julie Koslerich is wonderful as well, and she's been here for over, I think, going on 3 years now. They both are very experienced in collecting the data that we need, and we'll be happy to take the calls over the phone if you want to do it that way. So that's the phone number to call, or you can mail them to our Kentucky Department for Public Health, 275 East Main Street. Our mail stop is HS2EC. Please put that on your form on the outside of 2 confidential envelopes so it comes to our office. So here's some questions for you, and we'll ask for the audience to participate. So,
Here she is. Paula says, I got called away at the beginning. The new HIV form, does it replace the old form, or is it to be used in addition to the old form?
This should replace any old forms that you have. If we can go back to the actual form, you'll see a 2019 date, and that's the form to use.
Okay.
Well, it's actually, if you look at the adult HIV confidential case report form on this document that you see here, right here, there'll see a 219 date, and that's the form to use.
And for adults, is that 18 and over?
I think 13 and over.
Oh, they're, okay.
Yeah.
Okay.
And then there is a pediatric case report form, but most of the county health centers are not using those. But if you get that case, call us and we'll be happy to walk you through the process.
So this form, the adult case reporting form, should be used for individuals 13 and older.
Yes.
Thank you.
Okay. So what could be a positive AB test and a negative Genius test, both state-run lab tests, be a sign of? Potential acute infection, so that means the person is in the process of seroconverting. So they are infected, they're producing a great deal of HIV in their system, and they can more easily transmit HIV to their partners during sexual or needle sharing activities that are not safe. It could be a potential false reactive, but we don't see a huge number of those. And it may potentially be human error. So it's not an absolute guarantee that it's acute infection, but that's the first thing we're going to think about. What do you tell the patient if you have a reactive rapid finger stick, the SureCheck, at your county health department, but the state lab sends you back a negative or an indeterminate result on the sample submitted? Okay, so with those indeterminate or with those results that are disparate, we're looking at a potential, again, acute infection. What we would want the patient to do is we would review with them their potential risk. It might be a false positive, but we want to compare that to the risk. If they tell us that they're having sex or sharing needles with somebody, there's a risk to some degree that they could be HIV infected, and this could be a sign of acute infection. We'd want them to come back 4 weeks from their last potential exposure. So you'll need to say, when was the last time you had any unprotected sex with anybody, not somebody you're concerned about or not maybe your present partner, but anybody at all? And when was the last time you shared a needle with somebody? From that date, come back in 4 weeks. If it's been longer than 4 weeks already, have them come back in about 4 weeks from the time you drew the blood. If the person is infected, and we talked about this already, they can more easily transmit HIV to their sexual or needle sharing partners during their acute infection. Who wants to tell me the difference between qualitative and quantitative RNA? It's basically what it sounds like. Quantitative tells us how much HIV is in the sample that was sent to the lab, and qualitative simply looks for the presence of HIV in that sample. So it becomes that tiebreaker test when we have disparate test results in the previous screening test algorithm. So here's my contact information. I'd be happy to answer any questions that you have. Just give me a call or shoot me an email and I'll respond. If I do not know the answer, I'll be happy to find the answer out for you and follow up with you as soon as I am able. Thank you for your time today. Thank you for helping us diagnose folks with HIV. And again, call us if you have any questions.
Thank you, Bob. And just to reiterate, the HIV forms are now in the form section of the CCSG. In the past, it was a little bit difficult for folks maybe to find those forms. And so I just wanted to let everyone know that they now are in the form section with all the other forms. And so hopefully that will be a little bit more user-friendly for the local health department nurses to be able to access those forms. So thank you for sharing that information with us so we could put it, so we could get it posted.
Great.
Okay.
Thank you very much.
Thank you, Bob. Okay, so next I'll invite Benita Decker to come up. Benita is our Family Planning and Adolescent Health Program Director, and she's going to talk to us today about being youth-friendly, and she's going to talk to us about sparks. So I think you'll be interested in this concept and to learn more about how your clinic and you yourself can become more youth-friendly. Thank you, Benita, for being here with us today. And I'll get this out of the way, okay?
Well, yeah, you can. We're going to be up and down on that. Good morning, everybody. I want to do what is a fairly new concept that was called a spark, and it was these sparks have been created by the Adolescent Health Institute at the University of Michigan, and they're really great. They're like a 15 to 20 minute little training that will centered around adolescent health. And so they're not a long presentation, and they're very interactive. Now, doing this as a webinar is going to be a little challenging. So I need you to pull out your laptop. I mean, whatever you're on, you're going to need your keyboard, and you're going to have to be brave, because we're not going to get as much out of this presentation if you don't interact. So if we were in person and face to face, I would, like point at people, but I'm not going to be able to do that. So to make this really fun, it's supposed to be fun and interactive. I really enjoy this format. And when I learned about it, we did it as a webinar, and it works. So there'll be times where you're going to have to type things into your question box. You're not asking a question, but we're going to work together and just, it's almost like we're all in one great big room. So be ready to, please don't ignore me. Please, participate with your question box as we move forward with this. So Sparks, there's all kinds of topics that AHI have created. We're going to do being youth friendly, and then if this works out and we feel really good about this little presentation, we may do the other ones in other PHM webinars. Other topics they have are strength-based approaches to adolescent health, adolescent brain development, cultural responsiveness, for adolescents, nonverbal communication biases, and being an askable adult. So I'm hoping this format, hope this format works, and we will continue on with this to give you just a little break. This is not so heavy, but it's going to be really informative. How do I go down? Just arrow.
What are you trying to do? Advance the slides?
Yeah. How do I do that here?
Next.
Okay, so all of you should have gotten a handout. It's kind of a two-part handout. I hope you printed it off. If not, the top section is right here on your screen. I want to just take a few minutes, so we'll have some dead space for a few minutes. I want you to look at these questions and ask yourself, how I felt like in my teen years, and just go through there and just spend a couple minutes. If you're in a room with other people, you can talk amongst yourselves, and just we'll spend about 2 minutes or so as you look through these questions and just jot down some of your answers. There's no right or wrong as you think about these 9 topics. So I'll give you a couple of minutes to look through this. All right, ladies and gentlemen, if you're there, okay, as we look at this, and think about what you put. So if you think back to when you were a teenager, some of you it wasn't that long ago, and some of you, like me, it seems like it was, because it was decades ago, that it was a long time ago, but we all tend to remember our teen years. Some of you, through questions, share with me about what was important to you when you were a teenager. What were the things that were important to you? All right, so, but as you think about, I know when I was a teenager, I think I have to remember this a lot because of my job, but I can say that it was a confusing time, and priorities to me might have been boys, that might have been exceeding in school, it might have been, we didn't see a whole lot past our future, especially middle school and stuff. When I was in middle school, it was, working toward that driver's license. Things that were important to me were being accepted by my peers, that kind of thing. Somebody tell me, oh, look, here's our girl. She's going to help us. Here we go. Got lots of them. Friendships, friends, social stuff, running, money for social events, friends, fun, wanted to be fun all the time, fitting in and being accepted, fitting in, being liked by others. Excellent. That is where they're at, right? Okay, so as you work with teenagers today, what makes it kind of hard to work with them? You all type in again. We've got Jamie here. She's going to help us out with this. So what are some things that really help, what are the things now that really challenge us today working with teens, that you find a challenge working with them? What's hard about it? They're on their phones all the time. Yes, they are. And they don't see the big picture, right? And they only see them, right? They're very centric. That's where they are in their development. What else do we see? Good job, folks. It never happens to me. That's right. You know, I won't, this won't happen to me. You know, I can take risks. And the other things is that, you know, you tell them, you know, you can't do drugs, or you can't have sex or do whatever because all these bad things can happen to you. Well, you know, my friends do that all the time. Nothing bad ever happened to them yet. You know, they don't see that, right? What is some of the fun things about working with teenagers? Girls' self-esteem lower and no confidence, right? But so what are some of the good things about working with teens? What are the best things about working with teenagers? And Amy wrote that they have potential to change things, and that's right. And you have a potential to influence their decision making, right? They do have a fresh perspective. I get really frustrated with people who want to do programs and do activities for youth and don't ask them what their opinion is about it. They're smart and they have a fresh perspective. They're excited about life, not jaded like us, laugh out loud. Okay, yes, they are. And that can be refreshing. And they can think outside the box. It is fun to think with them about that. I find it fun because you can make a difference. And so helping them learn trust and respect and that type of thing. Any other comments as we do that? Okay, so thank you all for participating. And those of you who didn't, I know you're thinking through all this, and that's really exciting. So we did this activity to help us think back to our own experiences as young people and to remind ourselves that it might take a special effort to meet their needs as we provide patient-centered care. And that is not just in the exam room, but from the front desk to the exam room.
Do you have any other question and answer pieces?
No, I didn't see any. Did you?
No, I mean, will we do that same scenario again?
Yes, we will. So hang in there.
Okay.
Hang out, Jenny. Okay. So then how do I go next?
Just click on the slide,
Oh,
and
okay.
then you should be able to hear it.
All right. So here's a new challenge Jamie needs to hang out with. We're going to look at what youth say about youth for an adolescent-centered medical home. So we're going to work on. So I have to go. We're going to get that video up. Jamie embedded it for us earlier. And so we'll watch this video. If you're on the phone, you won't be able to hear the audio. So the audio will come out of your computer, I think. So this was a slide from, a video that was of course was produced by the AHI folks, but it was from their teen advisory counseling. So these were real youth who created this video and wanted to share it with the world about what they would like to see in a youth-friendly center. So let's think about that. What might happen if a youth doesn't feel comfortable when they come to your health department and to your clinic? What might happen to their healthcare experience and what effect might that have? Again, we got to type in. So we'll let Jamie get to that if anybody wants to comment. What might happen when teens don't feel comfortable? May not come back, discourage friends from coming, and they could have a poor health outcome. And then they aren't going to tell you the truth. That's exactly right. That's really important. If they don't feel comfortable and confidential, then they're not going to release information to you if they don't trust you. And they're not going to tell their friends. And and so I know that teens can be challenging, but what you do is really important, and you may be their only access to care. They're not going to maybe feel comfortable going to their pediatrician. And so about stuff that they could come and talk to you about. So what will happen when, we can flip that, and see that just reverse, right? What might happen when teens do feel comfortable with their healthcare experience? I know they'll come back and hopefully come back, tell their friends. Is there anything else that you can think of that they might also do? They might listen. They might get compliant with their care, right? They may tell you more about what their problem for the visit was, especially if they're like being coerced or there's some issues in their lives that they need a trusted adult to talk to. Absolutely. So that's really good stuff. So we'll go on to the next screen. I'm just kind of letting Jamie know. So while teens are in this transitional stage of life, we know from research that teen brains are at a critical point of development. The part of the brain that controls executive functioning, which includes judgment and cause and effect, is not fully developed until about the mid-20s. When teens make decisions that seem questionable and you're thinking, where are they coming from? You know, it's helpful to remember that they're just developmentally not quite at that adult full judgment stage. And that way we can help them reason through that decision-making skill, but do that without doing judgment. Well, like, what are you thinking? Well, what are they thinking? Their brain isn't thinking like ours yet. A great example of how teen brain development is unique to this age has to do with risk-taking. People of all ages take risks, but it's at a peak during adolescence and can be both good and bad. We always think of the bad, but there's good stuff with risk-taking too. There are emotional risks, social risks, and physical risks that all help adolescents to build their identity. 3 out of 4, in fact, if you look at this, some risks can be damaging, of course. The CDC reports that 3 out of 4 adolescent deaths, diseases, and disabilities are a direct result of risky behaviors. This is disproportionately high compared to other age groups. This also means that there are opportunities for prevention, and we could change the outcome for a teen through a good screening and counseling visit. So if their behaviors are developmentally appropriate, as challenging as they may be, what can we as adults do to help them along the way as we, as healthcare professionals, do truly patient-centered care? So if you look at the bottom of your handout, it lists, grab the bottom of my handout, it lists some youth-friendly behaviors. Okay, and I don't know if all of you have yours, and I don't have them on the screen, so I'm going to read them to you really quick.
It was posted in the drop-down box, so they should
Okay,
have
so if y'all have that, read through those. Accurately discusses and applies confidentiality, provides and supports fair treatment and equal opportunity, listens to and objectively considers what the adolescent patient has to say. I think as providers, we want to do all the talking, but we really, especially with adolescents, we need to do as much or more listening as we do talking. Accommodate the needs of the individual, use positive body language, help adolescents navigate their referrals and other system things that they're going to need to do if they have issues. Avoid using medical jargon. We need to use medical jargon, but at the same time, make sure that they understand it and be more clear about it. And we need to withhold judgment. And so use sensitivity and maintain neutral language and body language with adolescents, helping them, knowing where they are and what they're supposed to do. So as we finish this up just a little bit, we're going to look at a few scenarios. In the interest of time, I would have you, if we were all together, just have you choose which one of these youth-friendly behaviors that they're modeling here or not modeling well. But I'll just go ahead and we'll talk about it. So here the scenario is, studies show that providers often don't counsel their adolescent patients with chronic illnesses on reproductive and sexual health, even though adolescents with chronic illness participate in sexual activity at the similar rates of their peers without chronic illnesses. And I'm thinking about things like diabetes or other health issues. So which youth-friendly behavior does this relate to? Number 2, it relates to the fact that we need to provide and or support fair treatment and equal opportunity for all adolescent patients. There may be other situations where we want to back off, or maybe they're a patient with special needs. They have some kind of mental health disability. Those kids are still growing and having puberty and having sexual, they're sexually active too. So helping, not being judgmental and helping them through that. The next scenario is Lewis says, who is 16, says, my mom talks to her and she talks to my mom. I'm just there. I'm just there to get poked. Okay. So which one is this one? Well, this one is talking about number 3, listen to and objectively considers what young people have to say. I think that that's easy to do because, you know, we're on a time constraint. And so instead of talking to the youth who is probably clammed up and not really wanting to talk to begin with, it takes a little longer to get them out of their shell. Plus, they're not going to talk with mom in the room or dad in the room. So if a teen is 14 or older, my suggestion is that you ask parents not to be in the exam room with them. And that can get a little tough because parents will want to answer for the teen too. And you're not going to get true answers without that. And I think it's okay to say, you know, or even if mom is there and she's talking for the teen, saying, you know, okay, but let's hear what Louis has to say about this, you know, and you know, or maybe you need to step out. I think we need to advocate for our teen. And then the last one is, let me get to it. This is the following story is from Ray, who is actually age 23, so she's at that emerging adult stage. When I explained to the staff that I didn't have insurance, she was like, oh, well, there's this program and there's this resource and you can get help here, or you can go to this route. And it was just like, wow, no one ever told me that. Otherwise, I felt doomed. And she kind of gave me hope. I've gone to other really nice places and the same thing. They were just positive about it. Like, that's no big deal. We can work with that. And there's options. Whenever I was given options and I didn't feel hopeless, it was a good experience. So when we think about this youth-friendly behavior, it's patiently helping youth navigate referrals and other systems that may be challenging. I've read other things where youth will say, oh, when they go in and say, well, I don't have insurance anymore. And the whole room looks at them like, oh, well, you know, we'll have to think about that. But being positive about that, especially with Title 10, you have the ability to provide care for them and have the reimbursement and help give them hope and empower them to take care of their own health. I lied, there was one other one. You have to explain that nothing bad is going to happen if I'm honest. You know, we talked earlier about the fact that, you know, if we don't give them the ability to be honest and be trustworthy, and the confidentiality thing is a big thing. Sierra, you know, is referring to nothing bad is going to happen. And she's talking about, like, you're going to tell my parents, you know, it'll leave this building. She's not talking about nothing bad is going to happen. But now on the same hand, if she's going to be honest with you and there's mandatory reporting stuff going on where she's telling you things that by law you need to report, then you need to help work through that system with her and bring her along and say, you know, we can't keep this quiet when it's something where she's getting hurt or someone else is getting hurt, but say, hey, let's work together and make her a partner in that reporting and that partner. Don't leave her out to dry, you know, make sure you include her in those decisions and in that mandatory reporting. But other than that, you know, we don't have to share anything. And so that's another youth-friendly behavior. So as we go forward, thank you for your time. We're going to keep this conversation going. I'm going to send all the nurse leaders these little sparklers, like I think there's 3 of the handouts. Then I want to ask you to hang up in places where your staff will really see them, maybe in the bathroom or on a wall where they always look for things. And they'll be like little case scenarios and other things that kind of sparks their interest and kind of refreshes what we've talked about today. And so I'll have Joy send those out in the next 24 hours. And but I encourage you to print them out and use them, and we'll keep this conversation going. Also, if you kind of like this format and you want us to do more sparks, I think they're really good. They're quick. Let Joy know or me know, and we will work that out and do some other ones in future meetings. Do you want me to talk about folic acid really quick?
Yes, if you want to, that'd be great.
All right, we're going to switch gears for a second. I've had a lot of questions about the folic acid stuff. I talked to Cynthia Robinson today. Her advice was, first of all, make sure you're using the new PEF and not the older PEF, because they removed the WO506 for multivitamins, FR and CH. There is one for first bottle and subsequent bottles. She said that you should be able to put a quantity in. She's checking with CDP to figure out if that's not happening. And she said if it's not happening, she will have it fixed immediately. So we are encouraging that you give however they come, 3 or 4 bottles, however it comes. But you should be able to mark quantities, and it really doesn't matter which WO506 you put. She's also going to fix the PEP. She's got other things they're going to revise on the PEP, and this will be one of them, to make sure you know you can put a quantity in and not just a check mark. And so this should be fixed within the week, she said. And so email me if you have issues in 7 days from now, you're still having issues, getting that put into CDP, please let me know, and we will make sure we continue to work with local health operations to get this fixed. But she said this will be fixed within the week.
Okay.
So
Thank you, Benita.
you're welcome.
Are we ready?
You're ready. Go right ahead.
All right. Good morning, Gary Franklin. Once again, thank you for having me. I am the CADA Liaison Advocate for the Options Purchasing Program. Want to thank again Joy personally for inviting me, because it's a real pleasure to be able to stand here and talk to our nursing leaders across the state to talk about this exciting program. I met with Allison Adams yesterday in Louisville, and we had a very long discussion about where we are and where we're headed. And I feel like we both think that we are leaps and bounds beyond where we started 2 years ago. And this is an exciting program. For those of you that are hearing me for the first time, I, along with Rowanya Rice and Allison Adams, began the CADA Options Purchasing Program. It's a program that you can utilize to purchase supplies at a much lower price. And we're doing this across the Commonwealth. And most of you have heard about it through your health directors, because they've been privy to a lot of that information. But recently I found that, you know what, all the nursing leaders across the state need to hear about this program, because a lot of times these things get pushed to the side because of other important projects within the Commonwealth that the health directors focus on. And it's usually the nurses are the ones that usually call me to say, okay, now the ball's in our court, let's get this going. So one of the things that we do is put together a purchasing agreement, meaning there are options for you to buy products at a much lower price. And what we also try to do is use peer group testing within the Commonwealth for products to see what the nurses think about these products across the board. One area of this was we really found that we were having problems with nitrile gloves. Now, if you've been in this industry or profession a long time, you know it started out with people were using vinyl or latex, and you had latex allergies, you switched to vinyl, and vinyl's not a very good glove when you're doing any type of examinations or shots. So most people went with a nitrile. Well, nitrile was really expensive for a long time, and now the prices are starting to fall. There are very few latex or nitrile allergy reactions to this type of glove. So we found a glove line, a manufacturer, that they wanted to write us a specific agreement to the CADA Options Purchasing Program for price. And I've listed it on the board here, so certainly I can get that information out to you, or you can just jot it down real quick. $9.32 a box. However, there's 250 gloves in a box. So I can remember the days when nitrile gloves were $17, $18 a box for a box of 100. Now the price has been driven down, and we've gotten to $9.32 for a box of 250. We've got those ready to go within the CADA Options formulary, and you can order them today through Concordance. You're going to have the option of doing that through other distributors as well pretty soon. But for right now, Concordance, and it's the Simpermed Ultra Nitrile. It's a really nice glove. The folks at Christian County were nice enough to be able to do some peer group testing on that glove, and they gave it a thumbs up, said it was a great glove to move forward with it, and we did. So there's the information right there. And I want you to understand too that there are a lot of glove options out there, and you have options on other gloves, But what we try to do is standardize to use our volume purchasing power to negotiate better pricing. And that is what this program is all about, is to take what you buy today and take what your neighboring counties and neighboring health districts purchase, and let's see if we can't somewhat standardize, then use that volume to drive these prices down. That's what this entire program is about, is finding an opportunity to not just save money, but just narrow our margins, lower our prices. We need lower prices, and that's what we do here. Do I need to advance this, Joey?
Yes.
No, you can do it on the screen, just click this, it won't go on the, either arrow down or click the screen. If you click on the screen, it should advance.
You just show me which button. Oh, sorry. Okay. It's that button. One of the things that we were able to do in this program, and this is exciting for me, because when we talk about trying to find ways to save money on medical supplies, office supplies, janitorial supplies, just about anything that you buy, this goes down to medications, injectables, women's health, multivitamins. We needed a national GPO, a group purchasing organization, to partner with to be able to access lower pricing. And I'm going to spend just a little bit of my time on this today, because you need to understand it to be able to utilize it. A group purchasing organization is not something that you own. It's something that you partner with within your county. In this case, if you're a member of the CADA Options Purchasing Program, you will automatically be a part of the Provista Group Purchasing Organization. What that means in simple terms is when you log in to purchase something, the system is going to automatically search out where you got a contract price within Provista. So you may, let's take a BD syringe. Let's take a 23 gauge by 1 syringe. Typically, up to now, you had been ordering those and you get a marked up price from a vendor. They may pay $20 for it and they may charge you $28 for it, and that was your price. Well, what this does is allow you to buy this at a much lower price, because it's already searched out that Becton Dickinson contract for you. And when you put it in your cart, it's already sourced the group purchasing organization price for you. And in other words, the distributor will sell the product to you and you get a rebated cost on that. It will save you a lot of money. And most hospitals do this, not most hospitals, all hospitals do this every day. That's how they purchase product. I said we wanted to get public health in Kentucky to get on that level, that plateau, where we get the opportunity to buy products at those type of prices. And that's what we can do through Provista. You don't have to sign up for this. It's already done. Once you become a member of the Options Purchasing Program within CADA, then you're ready to go with this. And I'm very excited about this. You'll get more information about this as we move forward. The next thing is needle exchange programs. My goodness, I have gotten a lot of calls about needle exchange programs, and I've gotten a lot of calls about what should we do, or we're starting a new needle exchange program, or we already have a needle exchange program in effect right now and we're looking for better pricing. Well, you've got it. Through Provista, the GPO, you have access to, for instance, Covidian and Becton Dickinson syringes at a rebated price. Now is the time to start looking at different opportunities within the syringe world to try to find something that we could even lower the price even lower than that. And this also spans some of the other clinic areas that you have. If you're looking to save money on syringes, we have some options for you. One is, pardon me, MHC. MHC makes a line of syringes called the Easy Touch syringe, And you can see the boxes on the screen. I'm assuming they can see me, Joy, but I've got a box of them right here.
They're seeing that screen.
Okay.
Here.
They come in a box of 100, 5 boxes to a case, but they also come in bags of 10. So in this case, when you're running a needle exchange program and you have a patient that's standing on the other side and you're getting ready to give out those syringes to them, they already have them prepackaged individually in bags of 10. So you can just, let's say a patient is going to get 60 syringes for that day of that clinic. You can just reach in and grab 6 bags and hand them those. You don't have to count out 60 syringes. The other thing is Lexington Fayette County Health Department has just converted to this particular syringe line because of the cost savings. They were buying Covidien, they were buying Becton Dickinson, but as you probably have found out if you buy very many syringes, that Covidien had a national backorder situation because of this. In this case, Lexington Fayette typically uses a 29 gauge, 1 cc by ½ inch needle. And we have a MHC brand syringe and needle combination. Now it's not retractable, but Lexington Fayette did not want the retractable syringes. Other counties do want retractable, and we're working with you on those opportunities out there. I like this. We talked a lot about retractable, safety lock, everything you can think of. And when we get down to talking about what we really want, I know some county commissioners have said safety's what we're going for. We want something that retracts. In investigating this, I have found that there are retractable syringes and needle combinations out there. Vantage Point's one by Retractable Technologies, which we have on contract through the Options Purchasing Program. We also have the Becton Dickinson Integra series that's on contract through the Options Program. But what I found is that a lot of these retractable syringes, once that user pushes that plunger down to inject what they're injecting, they actually can reuse that if they don't go ahead and push it all the way in and click it locked. So there's an education process to this as much as there is a mechanical process to this. MHC has the sheath lock syringe that we've had a lot of buzz about, where the user just pulls the syringe back and pops the sheath in place. It can't be used anymore. Once that clicks into place, it's done. They drop it in the container, and then they go back a few days later and get their new syringes. So I just wanted to get that out there because I am talking to a lot of needle exchange programs right now about the options, about trying to find ways to save money on syringes, and we have a couple of options there. Also, I wanted to touch base with you again. We have the Assure Prism Multi, which is the blood glucose analyzer. So if you're having to give these out to your patients in clinics, we have something that we have available to you. The meters are free, and the test strips under the Options Purchasing Program are 50 strips to a box, and they're $10. So you can't beat the price on these. I can get you as many meters as you want. I'll have my contact information listed in just a moment, and you can reach out to me and say, we really would like to convert to this. Again, we're trying to standardize to something that we've negotiated a really nice price on. Here's my contact information. I get calls every day from health departments saying, I want to get signed up. We want to get going with this program. And it's as easy as just contacting me through the email address or picking up the phone and calling me. This is my cell phone. You can text me. Whatever you need to do to get in touch with me, I'm accessible. I work for you. So please take a moment to jot this information down and give me a call. If your county wants to get to be part of the Options Purchasing Program, it's pretty easy. If you're with CADA, you can be a member as early as tomorrow, and we'll get you signed up for that. I want to take the moment to thank you, and I hope to be back here real soon to talk to you again about these exciting programs.
Thank you so
Thank
much,
you so
Gary.
much. I appreciate it.
Appreciate your advocacy and the information and serving as a liaison for access to these quality clinic supplies.
Absolutely.
Yeah. Okay. Troy, do you want to come on up? And many of y'all already know Troy. She's our state influenza coordinator. And I invited Troy to come down and say a few words, a few bullet points, share with us an update on what's going on in the influenza world. I know that some of you have already started receiving some of your private stock influenza vaccination. So wanted to go ahead and provide information about where the state's headed, talk a little bit about flu mist, CCSG protocols, so forth and so on. So you could go ahead and have that information in preparation for the upcoming flu season. And wanted to kind of be proactive in that regard, since we certainly have the HIV outbreak going on as well. So Troy, thank you so much for being with us today and coming down and talking to the group. We'll get your pretty face on the camera here in just a second.
That's quite all right. Okay, well, good afternoon, everybody. The flu season is rapidly approaching. Actually, flu season has really never ended this year. We know that 2017-2018 was a particularly horrible year. Hopefully later in this season, I'll be able to give you an update and go over some of the numbers and some more detailed information about flu vaccine at that time. ACIP has now recommended flu mist for the 2018-2019 season. It was not recommended for 2016-17 or 2017-18. And the reason for that is that the H1N1 strain in flu mist was virtually useless. So because of that, they have changed the strain of H1N1 to a Slovenia strain that was actually seen back in 2015. The problem is that there's no vaccine efficacy studies, no data that really shows that this is any better than it used to be. So for that reason, the American Academy of Pediatrics is really advising that only injectable vaccine is used. So ACIP says that they have no preference.
There you are, Troy.
Oh, yay. ACIP says they have no preference on what type of vaccine is used as long as it's age appropriate and the health status has no medical contraindications. Since pre-booking had already occurred for flu vaccine, the Department of Public Health has determined that we will not be ordering flu mist this season. Now, you do have the option to buy that as private stock, but just keep in mind that if you do administer it as private stock, your medical director will have to develop and sign an independent protocol, because that is not in the CCSG, because we are not offering it. If they continue to offer it next year, we'll have it in there. Let's see. So if you know, we didn't want to see a bunch of vaccine get wasted by trying to order it at such a late date. And again, we're not really for sure that it's going to be any better than it was previously. So no changes to the influenza chapter of the CCSG at this point. Just be sure and read the package insert to make sure that you're giving correct dosage. And that is in the CCSG. The local health department billing and coding information will be distributed by the end of this month. They're currently working on that, so just hang in there. We do know that there are health departments that are receiving private stock vaccine. It's really early. Actually, that's kind of surprising. But the VFC vaccine, the orders will start processing at the first part of September. We like to make sure we have 25% of our allocation ready before we start processing those orders. Just keep in mind that local health departments should not borrow flu mist to give to VFC patients. We will not be able to replace that private stock. And again, if you do administer private stock flu mist, you need to make sure your medical director has a protocol signed. And private stock flu mist can be reimbursed by billing the insurance company. So the composition of the flu vaccine, the injectable, has changed somewhat this year. The H1N1 strain remains the same as 2017-2018. The H3N2 strain will be changed to a Singapore virus. H3N2 was our predominant virus for the 2017-2018 season. The influenza B Victoria lineage will be changed to a Colorado virus. And then in the quadrivalent, those 3 strains will be, to that will be added the influenza B Yamagata lineage, which is also the same as 2017-2018. We have gotten some really interesting information about how flu vaccine can reduce heart attacks. It's actually very significant data, and hopefully a little bit later in the season, once we get the CDC's final numbers on what 2017-2018 looks like, we can give you all that information at the same time. But we do actually have some handouts that you can put your health department's logo on. And so that might be helpful in order to promote vaccine. But I can tell you that the number of cases that we had for this last season was more than triple of what we had seen in the 2016-2017 season. We saw about 6 times more flu-related deaths than we had seen the previous season, and we saw a significant number of long-term care outbreaks. So one of the focuses that we really need to look at for this coming year are promoting high-dose vaccine for our senior citizens, people 65 and over. As we get older, our immunity wanes, and so those high-dose vaccines have 4 times the antigen that, so hopefully you could make up the difference there. And also pregnant women. Kentucky is among the lowest in the nation on our vaccination rates for pregnant women. And so we really need to get those numbers up. That's something that we're on a task force with Medicaid to try to help with their patients. So that's all I have. So if you all have any questions, my email is troy.cunningham@ky.gov. And my number is 502-564-4478, and my extension is 4273. And I appreciate your time.
Thank you, Troy.
You're welcome.
And then the handouts about the research with influenza vaccines potentially reducing the risk of heart attacks. Is that information, have you already sent that out, or is that forthcoming, or just want to let the nurse leaders know when and how to look for that information?
That information was actually just presented to us Tuesday.
Oh, good.
So it is, it's hot off the press, and
Okay.
so we're in the process of trying to get that together to disseminate to public health departments and to providers.
Great.
Okay.
If you'll include me on
Oh,
that,
of
then
course.
I'll be glad to share that
Yeah.
as well.
Okay.
Thank
I
you
appreciate
again,
it.
Troy.
Thank you.
Appreciate it. Okay, I have probably about 5 minutes of updates. If you can hang in there with me for 5 more minutes, that would be great. If not, I know we're running over our time, and I certainly understand your other obligations. One, I wanted to let you all know that there were some forms that were added to the CCSG. You will not need your medical director's signature again. We've added actually forms in Spanish versions, Spanish translations. They're in the form sections, and those Spanish translation forms include mammograms, benefits and risks, breast self-exam versus breast self-awareness, the ACH 40, improving health for women, the FPEM 13, fertility awareness method, and the history and physical 13, the initial adult assessment. So all of those forms did have changes on the English version for the July 1st CCSG, and so we had to submit a request for the Spanish translations, and they're now posted in the CCSG form section for your use. Another change to the forms section that we did make was for the IMM2, which was previously called Immunization Religious Exemption Form, and then the IMM2 instructions. Those two forms were deleted and they were replaced with the Commonwealth of Kentucky Parent or Guardian's Declination, Religious Grounds to Required Immunizations, and then the Commonwealth of Kentucky Certificate of Immunization Status. So if you'll look, those two forms have been added. Both the Declination on Religious Grounds and Certificate of Immunization Status, those two forms were added. So please look for those in the CCSG form section. If you have any questions on the immunization form, certainly you can call Debbie Donovan, who with the immunization branch, or you can call myself and we'll be glad to help you find those forms. I wanted to remind everyone about the APRN conference, which will be held Tuesday, October 16th and Wednesday, October 17th at my old Kentucky home in Bardstown, Kentucky. I sent out on Monday or Tuesday afternoon the information about the hotel reservations and the block room rate, which is $149. So we have about a month to make those reservations at the discounted rate. If you have an APRN who plans to attend the conference this year and she needs room reservations and she may not have access to email for some reason, please feel free and please be sure to share that information with her about the hotel at Hampton Inn so she can go ahead and get her room reservations made. And then I wanted to just point out that on, let's see here, on Tuesday afternoon, I sent out the statewide assignments for the Office of Inspector General's CLIA surveyors. And so they've split up the state, like we often do, into thirds by surveyor. So Marla Lyons, Truman Taylor, and Shane Hardison are our three CLIA surveyors who work under the Office of Inspector General umbrella. They are wonderful resources for local health departments who may have questions about the certification, the CLIA certification process, CLIA certification requirements, quality assurance. So I've included their names, their email addresses, and their phone numbers. I found them on this email. I found them to be very responsive and knowledgeable about the information. And so please feel free to reach out to them, and if you need technical assistance or have questions about your CLIA certificate for your lab. Okay, and then the last piece of information I wanted to share with you. We have had some retirements and changes in staffing here at the department as it has been across the state. And I wanted to let you all know that Sarah Robeson, many of you all know Sarah, she's been here for several years with the department as an epidemiologist. She has been named Acting Division Director of Epidemiology and Health Planning, which is one of our 7 divisions here within the department. And then Christy Royalty has been appointed as the interim lead for the immunization branch. And so she will be, Margaret Jones retired as of August 1st. And so Christy Royalty will be serving in that capacity as an interim role. And so if you have any questions about the immunization program or you need to know who to go to for immunization questions, please feel free to contact Christy, and I know she'll be able to help you all. That's it for today. Our next public health webinar will be October 18th. It'll be fall, and we'll be full into the influenza season. So thank you very much. I apologize for the technical difficulties we've had. Right up there at the top is user error as far as, quality assurance. So we'll continue to work on that and try to make that process better and improved. Appreciate all that you all do. Have a great day. Hope you stay dry where you are, and we'll talk to you soon. Take care. Bye-bye.